Dr. Kristian Niemietz joins us to discuss his Paragon Initiative paper, Diagnosis Overrated, an analysis of the structural flaws in the NHS. Dr. Niemietz, the Commonwealth Fund recently said that our healthcare system was the best system in the world. The OECD just recently said it was one of the worst healthcare systems in the world. Where does the truth lie?
They're both correct, they're just measuring completely different things. The OECD looks at health outcomes across a broad spectrum. They look at cancer survival rates, stroke survival rates, quality measures, infections after operations and so on. On those measures, the NHS is lagging behind most comparable countries. It's not catastrophically bad. You can get okay healthcare in most cases, but it's rarely in the top group for anything and is quite consistently below average. Whereas the Commonwealth Fund is, in that study, there's only one category that is related to outcomes, and in that category itself, the NHS is once again second to last, one of the worst. And so in that sense, where the two studies do the same thing, they come to the same conclusion again. It's just that most of the scope that I have is completely different. The Commonwealth Fund is mostly about procedures, inputs and more abstract concepts like equity and so forth. It's mostly, you could say, it's a box-ticking exercise, the Commonwealth Fund. They have a certain idea of how healthcare services should be structured and delivered, and it just so happens that the NHS mostly coincides with their idea of how a healthcare system should work. That's why it gets good ranks. So there's something to be said for both, but most of the time when people talk about whether a health system is good or bad or mediocre, what they have in mind really is outcomes. That would be the main concern for most people, for obvious reasons. And therefore, quoting the Commonwealth Fund study without bearing in mind what it actually says, that is where the confusion arises. That's what makes it misleading. The Commonwealth Fund itself doesn't say NHS is the best system in the world. That's what the media says about the Commonwealth Fund study, but those are not their words.
Doesn't the fact that the UK spends a smaller proportion of GDP on healthcare than many other comparable countries show that actually our system's quite efficient? All we need is more resources to catch up to the outcomes of other countries.
Yes, that is a common argument, and the problem with it is that low spending doesn't automatically mean high efficiency, and high spending doesn't automatically mean low efficiency. The OECD has also done a more detailed estimate of efficiency. They have modeled different healthcare systems as production functions, which turn inputs like funding and staffing levels and so on into outcomes, health outcomes. And they're trying to control for lots of other factors, like especially lifestyles on tobacco consumption, alcohol consumption, dietary habits and so forth. On their efficiency estimates, the NHS is actually one of the least efficient systems, and that is they fully take account of the fact that spending levels vary hugely between countries. So that really is about what healthcare systems get for each unit of spending. And what that shows is there are systems in the world where you could really argue they are as efficient as well, they all have some efficiency reserves, but there are systems where those efficiency reserves are not massive. If they want better outcomes, they really have to be prepared to spend more. So Mexico and Turkey, some middle income countries would fall into that category. The reason why these countries lag behind the Western world in terms of outcomes is really simply a matter of spending. It's because these countries are not as rich as Western Europe or North America. But the NHS doesn't fall into that category. It is quite far below the efficiency frontier. And you also get the reverse phenomenon. You see some systems, even though they have high levels of spending, are still ranked as very efficient. So the Swiss system is one of the most expensive ones in the world, but they are also the second or third most efficient one according to that estimate. So what that shows is you can spend large sums of money in a very efficient way, but you can also have low levels of spending and still spend that money in wasteful ways. So that there is no automatic link. You cannot just say, okay, spending is lower, therefore the system must be more efficient.
Many say that having an NHS which is largely state-run and funded provides a degree of democratic accountability over healthcare. How strong do you think that constraint is on the way healthcare policy is developed? How strong is that democratic accountability?
It's a popular argument, and which is a bit strange because we wouldn't really accept that argument in other sectors. It was prior to or in the 1980s when lots of industries were privatized. That was the common argument that especially Marxist academics made. They said if an industry is publicly owned, well, it means it's run by you and me, because we are the public, aren't we? So therefore, these are our industries. But that argument never traveled very far beyond the seminar room, because for most people, it just didn't feel that way. It felt that these industries were run by faceless apparatchiks somewhere distant, remote, and that had nothing to do with them. And that was correct, of course, and that cannot really be done in a different way. The reason is simply that most people have neither the time nor the inclination to get involved with the details of the day-to-day running, technical details of running our steel industry or our car industry or whatever it is. And that's why ultimately you have to delegate these things to experts, to technocrats. And democratic accountability then really only does consist of the fact that every 5 years we can vote for a new government, and maybe we like their ideas of how they think that industry should be run, but really the link between the choices that we make in that way and the way those industries are ultimately run is extremely tenuous. It's so roundabout and indirect that you could say it's meaningless in practice. And that's the same in healthcare. In fact, even this democratic link is extremely weak. In the paper, I'm looking at what political parties have said they would do once they're in power in their manifestos prior to elections. And then I compare that to what they actually do once they are in power. And maybe not very surprisingly, it turns out that there's almost zero overlap. So if you look at the big changes that have occurred over the past 2 or 3 decades in healthcare policy, you'll find that none of these changes were ever announced in election manifestos before. So whatever drove them, it was not public demand. It was not that the public mood had shifted, that large numbers of people were demanding any particular change in healthcare policy. It's just that in the political sphere, some ideas come creeping up and some of them get implemented. And the only democratic accountability that really does exist is, you could say, if a party gets confirmed in government, if it gets re-elected, you could see that as a post hoc validation of the healthcare policy. You could say, well, the voters were apparently okay with that. So the manifestos are usually quite clear on what has happened in the past. They usually do say, over the past 5 years, we have done such and such in healthcare policy, and we're planning to continue that. So yeah, as a post hoc validation, maybe, but it's never in the way that parties say, we are going to do A, B, and C, and the public then says, yes, that's the type of healthcare policy that I want to see. It never works in that way.
Obviously, we've got a huge demographic transition occurring over the next 2-3 decades. What are the main challenges, do you think, to the NHS as the population ages?
Well, aging on its own does add funding pressure. So even if you hold the budget constant or increase it in line with previous growth rates, it won't be enough controlled for demand. So according to one estimate that I've seen, aging adds another 2/3 of a percentage point to growth rates in healthcare spending. That doesn't sound like a lot, but if you keep adding that kind of demand, that kind of pressure year after year after year after year, then it does, in cumulative terms, add up to quite a lot. So it does mean that you have to row quite heavily if you don't want to swim backwards. And it also leads to changes in the composition of healthcare that will be required, because an elderly population has different health needs than a young population, where healthcare would mostly be about one-off episodes, some illness that you contract and that gets cured by some treatment and that is then gone and dealt with. That is no longer the case necessarily for people above a certain age, where multimorbidity, multiple chronic conditions are the main issue, where healthcare has to be more personalized, more long-term, ongoing, and also more complex in that sense. So more resources will be required and more flexibility to adjust to those conditions. That will, for example, mean we have to find ways of moving healthcare out of the hospital sector and into more decentral community settings, which are not just more cost effective, but also, generally speaking, more personalized. And we will need in one form or another, old age reserves. Because this demographic transition is not happening overnight. It's not that you wake up one day with a massively aged population, but these are things that we can quite credibly predict. So estimates of what the health profile of the population will look like in 2030 or even 2050 are quite credible. There's some factors that you cannot estimate properly, like immigration, but large parts are fixed. So birth rates won't change overnight, and the birth rates that we have today do predetermine what kind of profile we will have in 20, 30, 40 years time. So you can adjust to this by building up old age reserves in the health service in one way or another. What that would mean is that people would, as long as they're young, pay more for healthcare than their treatment actually costs. So let's say you need healthcare services worth £500 every year and you pay £700 in either taxes or insurance contributions, whatever it is. And the healthcare financing agency would put those 200, that excess funding, those extra £200 into some kind of conservatively invested old age fund, and it would then accumulate with interest and compound interest. And once you get to the stage where the old age dependency ratio reaches a critical level, you could then tap into that old age fund as a second source of funding. It doesn't all have to come from current taxation. So you minimize the burden on the economy by building up this extra pillar of funding.
In your paper, you suggest a constraint on all healthcare policy and discussion of the NHS, and that's the fact that the NHS is somewhat of a founding myth in the UK. What do you mean by that?
Yes, well, most countries have some kind of founding myth, or not just countries, political movements, all sorts of social groups have founding myths, some story that they tell themselves about themselves. In America, it would be Independence Day, and in France, it would be stories about the French Revolution. Can be anything. Most of the time, those founding myths don't have much of an impact on current day on politics, but here the important founding myth of the post-war era is the foundation of the NHS, and that has a massive impact on today's political debate. There is this narrative about the NHS as being an expression of the spirit of solidarity that developed under the extreme constraints and that people faced during the wartime period, and that created a new spirit of social solidarity, changed people's outlooks, made people more caring, more collectivist-minded, and that the NHS was then an expression of this mentality. But that is actually a post hoc rationalization. The NHS didn't really evolve in that way. Actually, the move towards a public healthcare system is longer than that. It stretches back longer, and if you look at opinion surveys from the 1930s and 40s, you'll find that you won't find much evidence for public demand for that. That was really an elite project. It was social elites. It was groups like the Fabian Society that were long toying with this idea of socialized healthcare, and the general public in the beginning just passively accepted that. So there were aspects of it, especially the removal of means testing, which existed before, that everybody should have access regardless of their means and that there would be no means testing. That was popular. Aspects like that had public approval, and there was public demand for some of those things before. But if you had asked the random person in, say, the early 40s, do you think the government should take over the voluntary hospitals? Do you think it should take over the friendly societies and should run healthcare entirely out of tax funding? Most people would have said, no, why? That's a very strange idea. And that is what opinion surveys actually show. There was no popular demand for that. That is something that was projected into the foundation of the NHS in hindsight. It was not there in the preparation period.